Hi everyone, welcome back to Psychiatry Network Journal Club, where we are going through the MOC articles put out by the ABPN one by one and reviewing them with different psychiatrists who have volunteered to sign up. So Dr. Dar is joining us right now, and it looks like she's being added right now. Oh, there she is.
Okay, hi.
Hi. How's it going?
Pretty good. How about you?
Good. Welcome.
Thanks.
Okay, while Dr. Dar is setting up, this is Dr. Saima Dar, and she is going over our article tonight, Treatment of Personality Disorders. And let me just briefly go through her bio. Dr. Dar graduated residency in 2008 at St. Vincent's in New York. She also completed a consult liaison fellowship at Montefiore Medical Center in Bronx, New York. And she's currently on staff as a consultation liaison psychiatrist at a Cleveland Clinic Regional Hospital, Fairview Hospital, for almost 10 years. She went into psychiatry because she loves working with the patient population, in particular in circumstances where people need emergent evaluation. She wanted to be able to advocate for an often marginalized sector of our population. And she has been a member of Psychiatry Network since its inception. And she and I went to undergrad and medical school together. So
I
welcome.
like to
And
say I knew you before you were famous.
oh, Saima and I literally met
Yeah.
the week after, at least the week after I graduated from high school. We went into a combined BSMD program. And so we started college together at Kent State University, like the summer, like we dove right into college.
Yeah, pretty
So very
much.
young. I was still
Yeah,
17. So
I was 17 too. Gosh.
and we were in
Oh
Ohio,
boy.
and but now look at us, like we're both CL psychiatrists, and so we actually reconnected a few years ago, one through the Psychiatry Network group, but also we've been attending some of the same conferences. She was also a program director previously
Assistant,
at
yeah,
Cleveland Clinic,
associate.
and I do
Yeah,
that too, associate program director. So
associate, yeah.
yeah,
Okay, so
well, yeah,
I'll get
go
moving,
ahead,
I guess,
yeah,
because there's a lot of info. Thanks for asking me to do this. It's sort of outside my normal comfort zone, which you know since we know each other.
yeah.
But since you asked, of course, I had to say yes.
Thank
And I'm happy
you.
to be here. So I work purely in CL psychiatry, so I don't really do a lot of therapy per se. But I was drawn to the topic because these are our most challenging patients. And so some very famous folks wrote this article, Doctors Bateman, Gunderson, and Mulder, on personality disorder and treatment of personality disorder. And I'm going to go through an outline that I kind of put together of the article for everybody. It was very dense. It's from 2015 in Lancet. And they start out in the introduction talking about the reasons why it's so difficult to research personality disorder, including reasons like the heterogeneous population, the comorbidities with other mental disorders, the disagreement about core outcomes and measures, issues in setting up studies, keeping studies double-blinded, and then also talking about how most of the research centers around borderline personality disorder and antisocial personality disorder, and not much research on the other personality disorders. So there's that. They also talk about what makes outcome robust, including, looking at the core symptoms of the disorder, and seeing if there is an effect from the treatment that is being done on social adaptation over the long term, which is not often seen, unfortunately, in personality disorders. So they use the organization of the cluster A, cluster B, cluster C, and did a review through PubMed and Medline, and they give you kind of what they did in doing their research or their review. And only English articles between 2008 and 2014. And then they did say that they supplemented with other landmark studies. They didn't really put a list specifically of what those were, but there are extensive citations for the article, I think close to 100 or maybe more. So they looked at the treatment approaches from psychosocial therapy to pharmacotherapy. They said that psychosocial therapy was considered first line for borderline personality disorder. And then they commented on how the context varies from inpatient to day patient or partial hospital to outpatient, that the length of treatment has varied over the years, and that the format has varied from individual to group to mixed. And one of the most important points that they made was that there's really no obvious relationship with outcome in looking at severity of personality disorder, frequency of sessions, or length of treatment offered. So I thought that was interesting because, you would think more frequent sessions or being in treatment longer term, would be more helpful. But they said that there's really no obvious relationship yet. They also raised the question of why use pharmacological treatment since there's such mixed reviews about that. And so we'll get into that in a little bit. They talked about different studies that looked at what dimensions we should be studying across personality disorders, and sort of the agreed upon 4 measures are affective instability, anxiety inhibition, cognitive perceptual disturbance, and impulsivity and aggression. But then they commented that the review literature shows that there's really little validity supporting studying these dimensions, but they're still used. So that was kind of amusing to me. Okay, what else? Let me kind of talk a little bit about studies or drug trials looking at borderline personality disorder and how the power of those studies was pretty poor. Okay, what else? Let's see. Most individuals diagnosed with one personality disorder meet criteria for at least one other personality disorder. That's a direct quote that I thought was interesting. And then they, highlighted the comorbid axis 1 disorders like depression, anxiety, alcohol, drug use, and just how prevalent that is in personality disorders. Something else that was highlighted, that response to antidepressants in depressed patients with borderline personality disorder is lower. So we often give patients with personality disorder, like borderline personality disorder, medication, but it's not necessarily going to be helpful. And that came up over and over again in the article. Okay. Then they also talked about psychosocial treatment, and that the aim is to reduce acute life-threatening symptoms. But sometimes, the pervasive dysfunction of the personality or the structure of personality isn't necessarily improved, although that's a goal. That's not necessarily the outcome over the long term. So one of the other important points they made was that the focus of treatment, so I thought this was an important point, the focus of treatment, behavioral, mental process, interpersonal, and social aspects of living, the context or the form of treatment did not make a discernible difference on complex outcomes. So again, the idea of, there's all these different kind of forms or ways of treating patients, but they haven't found that one specific way is necessarily the best. Okay, and then they went back to talking about the different, oh, you're welcome, Noreen. That's nice. Yeah, this was a hard article for me to read, I'm going to say. So I appreciate that. Thank you from her. Because there was just so much information, and it's not really anything I normally do. Like, I don't really normally look at different psychotherapies, or I don't even really think about a lot of this too much anymore on a day-to-day basis. I is the picture frozen? Okay. So
No,
then
you're
looking
good.
at cluster A, schizoid, schizotypal, paranoid, this part was really interesting to me because they discussed how there's not much studies done on therapy over the period of time they were looking at, because it's really not necessarily ego dystonic to these patients. So, treatment is really clinical evidence-based, like case reports and things like that. There's no randomized control trials um, for cluster A personality as far as medications go. So that was interesting to me. But I guess you could kind of expect that. And then there's a few small open label studies, they said, for schizotypal personality, but only for schizotypal, not for the others. Okay, and then looking at cluster B personality disorder, borderline antisocial, histrionic, narcissistic. Again, emphasizing that the research has been focused on borderline and antisocial. And they mentioned this over and over again, and it seemed, that they were saying that this is a problem, or not a problem, but an issue in psychiatry, that this hasn't been looked at more, but the other personality disorders haven't gotten as much attention or as much studies done on them. So talking about how the recommendations have changed over the last 40 years, and at first psychosocial treatment was more psychoanalytically based, and that case reports in the past had reported or indicated that you had to be extremely highly skilled, and extremely highly trained to be successful in doing therapy with borderline personality disorder patients or cluster B patients. And kind of how the therapies became very super tailored towards borderline personality disorder, like DBT or BPD, CBT, things like that, and just how prevalent borderline personality disorder is as well, citing percentages like 20% of hospital admissions and referrals
Mm-hmm.
in psychiatry consist of patients with BPD, and just kind of commenting on how super specialized therapists can't meet that demand, that it's really not practical for them.
Mm-hmm.
So, that what's going to happen then to this patient population. Also, the amount of training and time to be, well versed in treating them isn't always practical. But what they report is that, or in this article, what they reported is that you don't necessarily have to be super specialized. And panel 1 on page 738 of the article highlights the 5 common characteristics that they described, and that according to their review, that this was more important than being highly super specialized in treating BPD. So they, highlighted 5 characteristics: 1, having a structured manual; 2, patients assuming control of themselves; 3, therapists helping connect feelings to actions; um, 4, the therapist being active, responsive, and validating, so actively involved; and then 5, that the therapist should be getting consistent supervision, ongoing supervision. So, that I think is great, because according to their review, 2 of the 4 randomized controlled trials that they mentioned from 2007 till their time of publication, generalists, as they were referred to in this article,
Mm-hmm.
did surprisingly well in their treatment outcomes, which they summarize in panel 2 of the article on page 738. And so that, indicated that, as long as they were treatment providers who had past experience with borderline personality disorder, who were supportive, who would focus on managing life situations with the patient, so specific, tasks and problems, that interruptions were okay, and interruptions in the course of therapy was all right, and that it was okay to integrate, pharmacotherapy, group interventions, and family interventions. So things that someone who would be considered more of a generalist might be able to do. So, excuse me, I'm going to get some water.
Yeah, I attended
So,
Dr. Gunderson's. He has like a 2-day seminar or something that they go over treatment for borderline personality disorder for the general psychiatrist, kind of like what you're talking about. And
cool.
it was actually a great 2-day session, and I felt after attending that seminar that it really wouldn't be that difficult to manage a borderline personality disorder patient in my practice if you have the time and
Yeah.
energy for that, you don't necessarily need to refer them out for therapy. Obviously, it's probably not what anybody would want to do full time, but certainly you could pick up a couple of patients yourself and manage their treatment, um, psychotherapy, even without
Yeah.
knowing how to do DBT, which is what we think of typically as treating borderline personality
Right.
disorder.
Right.
So,
Go-to treatment. Yeah. No, I
yeah,
think they were trying to be very encouraging of that, especially because, as they said a couple of times, like there's practically speaking, that's a real, a big burden
mhm.
as far as like there aren't going to be enough super specialized therapists. I just remember in New York too, trying to refer patients to the
Right,
specialized groups was always really difficult because there was
it
always,
is.
way more patients
Hmm.
than therapists available.
Yeah.
Um, so, okay. So what else? Then they kind of branched off into talking about the pharmacotherapy of borderline personality disorder. And this had a lot of different conflicting information as far as different guidelines gave a different opinion. So hopefully everybody was able to sift through that. Um, they said that the APA guidelines recommend targeted and very symptom specific pharmacotherapy based on dimensions by Seaver and Davis: affective instability, impulsive aggression. Oops, I don't know what that was on my phone. Cognitive perceptive differences. But the UK NICE guidelines, then, that they spoke of, recommended avoiding medications, using medications for a week or less, using only if there's a crisis, and if any sort of comorbid medical illness came up, that you should stop or reduce the medications. And then they contrasted and brought up the World Federation of Societies of Biological Psychiatry guidelines, because I think, since each psychiatrist was from a different country as well, so they kind of gave a global view. And so these guidelines said that antipsychotics could help with cognitive perceptual and impulsive aggressive symptoms, SSRIs with emotional dysregulation, and mood stabilizers with emotional dysregulation and impulse aggressive symptoms. But then they talked about how a Cochrane review showed that there was no efficacy for SSRIs, some role for mood stabilizers and antipsychotics. So it was kind of a mixed bag. Oh, and then the Australian National Health Medical Research Council said that they did not support the use of medication. So overall, what I got out of this was that if you're going to use medications, there's the most support for mood stabilizers, and then they specifically mentioned topiramate and lamotrigine as well as valproate. And for second generation antipsychotics, specifically, they mentioned aripiprazole and olanzapine. And then, they supported more psychosocial therapy rather than using medications if possible, but did comment on how medications are still very commonly used despite the lack of evidence for it. Um, and then they kind of transitioned into antisocial personality disorder, and looking at what's been studied or what should be studied, and recommended that reoffense should be what the primary outcome measure is, as far as looking for improvement rather than psychological changes or behavioral changes in the patients. And that studies have recommended early intervention and shown that that's helpful for men and for women, and that CBT methods have been shown to have the most positive results. There's really been very little pharmacotherapy trials. I said only 3 small trials. And so, again, a population that's underrepresented. Um, and again, NICE guidelines showing that they don't recommend routine use of medications in antisocial personality disorders. And, the different studies cited all seem to concur that there really wasn't an improvement, which for me, since I don't practice psychotherapy or these type of therapies on a regular basis, it was kind of uncomfortable. Like, well, all we really do usually
Hmm.
is either prescribe medication or send somebody to inpatient psychiatry. So that was, really something to kind of think about. Okay, and then they looked at what studies had been done specifically for psychosocial cluster C personality disorders. and looked at psychodynamic therapy versus cognitive therapy, and said that distress fell more in the psychodynamic group. Um, then there was a different article in 2006 showing that CBT was more effective. So it's kind of a little bit all over the place. But the good thing was that it showed that therapy has been helpful. Cognitive and psychodynamic treatment resulted in the most positive effects. But no randomized controlled trials as far as for drug treatment in this population, um, which again is super important. But personality disorder is such a hard thing to have randomized controlled clinical trials for. So just to kind of wrap it up and talk about the main takeaway points. So evidence-based information on personality disorders is super limited, mainly because most of the studies are focused on, well, first, there aren't many studies. Most are focused on borderline personality disorder. There's small sample sizes. There's short follow-up with clinical trials. There's a wide range of outcome measures. There's poor control of coexisting psychopathology. They concluded that psychosocial treatment is helpful, especially in borderline personality disorder patients, and so there's hope for future therapy and research. And that structured treatment overall is best, especially using manuals. They encourage patients to assume control over themselves and be more of partnership in the treatment, and that active therapy works best. Responding, validating, managing life situations was important, and that therapists should be well supervised. And then they concluded that pharmacotherapy should be integrated into the psychosocial treatment, time limited, manage specific symptoms, and then withdrawn when the symptoms resolve. Um, and that targeted interventions should be offered for short periods of time, part of sequence treatment over a longer period of time. And that, well, what did I write here? Forget the last part. Okay, and that's it. So it was a lot of information. It felt almost like reading Another Worlds, like to me. I had not read this much about therapy in a while.
I
It's
agree
probably
with you
good
because
for
I don't.
me.
Yeah, I think when you don't practice psychotherapy, I mean, I don't read
Yeah,
about psychotherapy ever myself either. So,
it had been a
but it's good
while.
to, yeah.
I have to do my
But
research in a year or two, so
right. So it's good
yeah,
to remind ourselves of everything that's out there.
yeah,
So,
yeah.
well, good. I don't think there are really any questions. One question was just asking a general question about how many
Sure.
psychiatrists are out there who focus on borderline personality disorder as their whole practice. Um, and I think that's a great question. I mean, I don't personally know the
Yeah, that's
answer
a
to
great
that. So
question.
yeah, um, I I know like of one or two in the area who,
Sure.
but yeah, I'm imagining that there's a few out there, right? So
Well, I mean, yeah, I mean, I could say that my therapy supervisor as a third year resident in New York was CL Psychiatry, trained from, I think, Columbia, and then did that for a few years, but then ended up going into private practice purely in psychotherapy. And she
hmm,
did psychopharm when needed, but I think she had a lot of folks with personality disorder issues.
yeah,
So I always thought that was interesting that she was
yeah.
from CL to private practice and in psychotherapy. So
Yeah. And then one other person asked if what the most common comorbidity with borderline personality disorder is. I don't know if that popped up in the
I don't think they
article.
said specifically,
Yeah,
or I would have written it down because I basically like rewrote the article into PowerPoint. But
yeah.
I don't think they specifically said
So,
what the answer to that is. But I can look back and message that person if I find that info.
okay.
Yeah, and it might be in the article they reference in that section. So, like I said, I think there were like 100
Hmm.
citations
Yeah,
throughout the article, which is a lot, or at least it felt like a lot to me because
yeah,
I kept flipping back to see, what
yeah,
article they were referring to. So
yeah. So
anyway,
I
it could be in
no,
that
th
reference point.
Yeah, I think it's either, from what I can remember, it's either depression or maybe substance use is up there too.
Yeah,
But yeah. All right. Well, thank you again
no
for going
problem.
over this article. And everybody, the directions for how to claim your CME are up at the top of the post. Uh, the questions for this article will be posted shortly, just within the next 24 hours. So
Yeah, I was gonna say, I
thanks.
think I turned in my questions but forgot to send the gal what the correct answers are.
Yeah, that's okay.
So I need to do that.
We'll get them
Yeah,
posted in the next day. So,
yeah,
but yeah, hope everyone's MOC studying is going good. So,
yeah.
all right, have a good
I
night.
know I have work to do.
Yeah,
Thanks.
same here. Okay, take care.
All right.
Bye.
You too. Bye.